So the topic, as mentioned by Dr. Mustafa, is hydrocephalus and its types. It's fairly common topic, and I'm sure most of you must be aware with the term and its types. But I will try and make sure to show lots of images and clear the concepts regarding its types and the causes of hydrocephalus. So I'll start my presentation. I have no financial disclosure or conflict of interest in relation to this presentation. We'll start with the objectives. So we'll start with the introduction, followed by anatomy of the ventricles. We'll talk about the CSF dynamic flow, the imaging tools which are used for diagnosing hydrocephalus, what's the criteria of diagnosis, then causes and types of hydrocephalus. So we'll start with the introduction. It's derived from the Greek word hydro meaning water and cephalus meaning head. So there is excessive accumulation of CSF in this condition, which results in widening of the spaces in the brain. The most commonly accepted definition of hydrocephalus is active distension of the ventricular system of the brain, which results in inadequate passage of CSF from its point of origin within cerebral ventricles to its point of absorption into the systemic circulation. It's a condition of CSF circulation disturbance with imbalanced CSF flow dynamics of various reasons. So the dilatation of the ventricular system may lead to loss of brain cells, which results in a variety of neurological symptoms, stroke, and sometimes even death. The current treatments are limited and invasive, which include CSF diversion via catheter or endoscopic third ventriculostomy. So let's begin talking about the anatomy of the ventricles. So I'm sure most of you are aware of the anatomy, but it's just a quick revision. So these are the paired lateral ventricles. And the lateral ventricles communicate with the third ventricle. This is the third ventricle. They communicate with it through the foramen of Monro. Then the third ventricle is communicating with the fourth ventricle through aqueduct of Sylvius. This is the thin membrane through which the CSF flows into the fourth ventricle. And from the fourth ventricle, it continues inferiorly as the central canal of the spinal cord. It's known as obex. The fourth ventricle also drains into the subarachnoid space and basal cisterns via three foramina. So two are the paired foramina of Luschka, L for lateral, and single foramina of Magendie, which is midline. Now talking about CSF flow dynamics. So CSF is secreted by the choroid plexus in the ventricles, and then it travels through the ventricular system, enters the spinal and cerebral subarachnoid spaces, and is absorbed by arachnoid granulations into the superior sagittal sinus. The brain interstitial fluid is the source of 30 to 40% of CSF, and 20 to 40% is absorbed by the cranial and spinal nerve sheaths and at the cribriform plate, rather than arachnoid granulations. The CSF volume is approximately 150 ml in adults. 125 ml is distributed in the cranial and spinal subarachnoid spaces, and 25 ml is found in the ventricles. A volume of 400 to 500 ml is secreted, and approximately 330 to 380 of CSF enters the venous circulation daily. So this is just a quick revision of what we have discussed so far. And you can see that the CSF flow starts from the lateral ventricles, flows into the third ventricle, and from the third ventricle through aqueduct of Sylvius, it goes into the fourth ventricle, and from the fourth ventricle through cisterna magna, it goes into the lumbar CSF space and into the subarachnoid space, and from there it goes into the superior sagittal sinus. So these are the models of CSF flow. On the left is the traditional model, and the right, the figure B, is the present day model. So the model A, which is the traditional model, is also known as the vertical bulk flow model, which states that the CSF would flow along the ventricles and then the cisterns, and then it goes towards the convexity to be absorbed at the level of arachnoid villi. So in this, the flow is through the ventricles and then it flows into the arachnoidal villi. Whereas in the present day model, which is also known as the transverse bulk model, which states that the CSF is secreted in the lateral third and fourth ventricles and it's absorbed locally rather than flowing down. As you can see here, it's absorbed locally, and also at the pericerebral CSF space, the pericerebral CSF is also produced by the brain, is also absorbed transdurally at the periphery. So moving on to the imaging tools, first of all, let's talk about CT. So CT is reliable, fast, and with no need of metallic screening. It's extremely useful in emergency settings. It's also very useful in pediatric patients because they do not require sedation. It's also more beneficial in cases of localization of the tip of the catheter, which is placed in cases of hydrocephalus. One of the concerns for CT is risk of ionizing radiation, and that is minimized by low dose CT scans. But then again, when following up patients of hydrocephalus, there is risk of developing brain and lifetime oncological conditions. So ultrasound is extremely useful in neonates. It's routinely performed in our hospital as well, and it's used as a screening tool in infants when the anterior fontanelle is present. So these are the images of an ultrasound image of a patient in which we can see that there is dilatation of the lateral ventricles and there is no hemorrhage within the choriotalamic grooves bilaterally. So this is a simple case of hydrocephalus. Moving on to MRI, it's the current modality of choice for assessing hydrocephalus. It's used for surveillance of ventricular size, underlying etiology of hydrocephalus, assessment of drain patency, and assessment of parenchymal changes. So when using MRI to evaluate hydrocephalus, apart from the size of the ventricles, we have to look for additional features such as presence or absence of periinterstitial edema, which is seen in cases of acute hydrocephalus, stretching of the corpus callosum, effacement of cerebral sulci, etc. So I would want to talk about the role of DTI, which is diffusion tensor imaging. So DTI indices before and after surgery can be used as a marker of white matter compression in hydrocephalus. DTI basically is about the compression of the white matter in cases of hydrocephalus. And acute hydrocephalus is generally characterized by increased functional anisotropy in areas of compressed white matter and decreased functional anisotropy in corpus callosum. I'm going to show that in the subsequent slides. The increased volume of CSF frequently leads to pressure onto the adjacent white matter pathways, the corona radiata and the corpus callosum. So in this image, the ADC, the top row is the ADC, and the bottom row is of the functional anisotropy images. So the figure A and D are the healthy patients, and B, C, E, and F are the patients with hydrocephalus. In the ADC sequences, you can see that there is gross hydrocephalus, and in this figure C, there is asymmetric hydrocephalus. Now moving on to the functional anisotropy patient images, this is the FA of the normal patient, healthy patient. And in this, you can see that there are increased functional anisotropy involving the corona radiata bilaterally, which we had discussed earlier. So these are mid-septal view of 3 patients shown in the figure, which are on top again are the ADC sequences, and at the bottom are the function anisotropy images. It's showing the genosplenium and this is the geno body and the splenium of the corpus callosum. So if you look at the ADC sequence, in normal healthy patient, the ADC of the corpus callosum is hypointense. Whereas in these patients with hydrocephalus, you can see hyperintense signals within the corpus callosum. On the functional anisotropy images, you can see that there are hyperintense signals within the corpus callosum in a normal healthy patient, whereas there are reduced signals within the corpus callosum in patients with hydrocephalus. So these are pre and post surgery images of a patient who underwent surgery, and this is these are the ADC and again FA images at the bottom. You can see in the figure A that there is in the figure C that there is significant reduction post surgery in the ADC values and in the dilatation of the ventricles. And in FA images, you can see that there is significant reduction in the FA hyperintense signals within the internal capsule in post-treatment patient. So talking about the role of CSF flow study. So this is a phase contrast sequence in sagittal plane of a young patient. It was just a 2-year-old patient. And figure A is the rephased image in which there visible background. Figure B is the magnitude image in which the flow is bright. You can see that the flow is bright in this one with a suppressed background. Figure C and D are the to and fro pulsatile images in which one of them has the bright flow and the other one has the dark flow. So this is a patient, 3-month-old boy with hydrocephalus, and in the sagittal images, you can see that there is narrowing stenosis at the level of aqueduct of Sylvius, and in the phase contrast MRI showing absence of the detectable flow at the region of aqueduct. So this is a case of aqueductal stenosis. This is an MRI of a 16-month-old boy with communicating hydrocephalus, which is showing hyperdynamic flow. You can see the flow word at the level of aqueduct of Sylvius. And in the phase contrast images, you can see that the prominence of the CSF flow through the aqueduct of Sylvius. So another patient, this is a patient of Dandy-Walker syndrome in which you can see that there is a large posterior fossa, there is cerebellar hypoplasia, and there is stenosis of the aqueduct of Sylvius. And in the subsequent phase contrast images, you can see that there is no communication between the posterior fossa and the posterior subarachnoid space. So another patient who underwent ventriculostomy. So in this patient, you can see that there is a flow void in the floor of the, this is the flow void in the floor of the third ventricle. And in the phase contrast image, you can see the flow jet through the ventriculostomy. And then again in the phase images, you can see the flow jet through the, showing the pulsatile flow through the cardiac cycle. So what's the criteria for diagnosing hydrocephalus? Ventriculomegaly, Evans index more than 0.3. So what is Evans index? It's basically a marker of ventricular volume, and it's a ratio of maximum width of the frontal horns of the lateral ventricles and maximum internal diameter of the skull at the same level on axial sections. Then it's the enlargement of the third ventricular recess and lateral ventricular horns. Then thinning and elevation of the corpus callosum. Normal or narrowed cortical sulci. Periventricular white matter hyperintensities. Now moving to causes of hydrocephalus. The balance between production and absorption of CSF is critically important. And because the CSF is made continuously, medical conditions that block its normal flow of absorption will result in overaccumulation of CSF. The resulting pressure of fluid against brain tissue is what causes hydrocephalus. And the causes of CSF are often obstructive, such as cystic lesions, tumors, etc. More frequently, it is due to an obstruction in the ventricular system, which is the obstructing type, or in an interrupted CSF absorption of flow, which is the communicating type. In young adults and children, obstructive type is the most common one. So this is an image which is depicting the few causes of the hydrocephalus, and we are going to talk about most of them as we move on with the presentation. Pathophysiology again is decreased CSF absorption, increased CSF pressure, increased force against the brain, then the same pressure in normal sized ventricles, ventricular enlargement. So now talking about the types, broadly it's classified into communicating, non-communicating, and then into congenital and acquired. So if we further subdivide the hydrocephalus from communicating, non-communicating, so communicating is being further divided with when there is obstruction of CSF absorption, then the causes would be subarachnoid hemorrhage, meningitis, etc. And when there is no obstruction of CSF absorption, then the cause is normal pressure hydrocephalus. In the non-communicating type, there is obstruction of the CSF flow within the ventricular system, and the obstruction will be at the level of foramen Monro, aqueduct of Sylvius, and the fourth ventricular outlet. Congenital hydrocephalus is the one which is present at birth, and some of the causes are aqueductal stenosis, Chloroid cyst. So this is a case in which these are axial and flare sequences. And in the axial sections of the CT, you can see that there is a hyperdense area within the foramen of Monro. And on subsequent flare sequences, you can see that there's predominantly hypointense signal within the level of foramen of Monro. So the hyperdensity on CT and hypointense signals on flare sequences are attributed to the protein content of the cyst, and this is a case of Chloroid cyst, which is resulting in hydrocephalus. Again, another case of Chloroid cyst in which you can see these are axial T1 and flare images in which you can see a rounded cystic lesion at the level of foramen Monro, which is causing acute non-communicating hydrocephalus. So these are two different patients. A is the healthy patient in which you can see normal flow through the aqueduct of Sylvius. And in the B patient, you can see that there is aqueductal stenosis, which is demonstrating proximal hydrocephalus involving the third and the lateral ventricles. So this is another patient. On the figure A is the healthy patient, and B is the patient which is showing a thin membrane at the level of at the level of the aqueduct, which is a case of aqueductal web. Now, acquired hydrocephalus may develop at the time of birth or at some point afterwards. It can affect individuals of all ages and may be caused by injury or disease. So the causes are tumor, hemorrhage, post-infection. So let's talk about communicating hydrocephalus. It occurs when the CSF flow is blocked after it exits the ventricles. It is called communicating because the CSF can still flow between the ventricles which remain open. The exact mechanism is unclear, and the underlying pathology includes poor absorption, decreased compliance, and unrecognized obstruction, difficult to ascertain in few individuals. So one thing I would like to mention that NPH is a cause of communicating hydrocephalus, and it may be secondary to decreased CSF absorption. And the second theory, which maybe is because of the weakening of the ventricular wall, which is secondary to the white matter ischemia. So this is a case in which we can see that there are enlarged subarachnoid spaces with enlargement of the interhemispheric pressure, interhemispheric fissure as well, which is pointed here. And then you can see that there is mild enlargement of the ventricles. So this is a case of benign enlargement of subarachnoid spaces in infancy. It's fairly common in infants, and one question may arise that how do we differentiate it from subdural hygroma? So in cases of BESS, we see these prominent veins which we don't see in cases of subdural hyperoma. So this is how we differentiate it, and plus it's quite common in infancy. So this is a patient, which a 17-year-old child who presented uh, with with meningitis, and axial and coronal images demonstrate poor absorption of the CSF as evident by hydrocephalus and periventricular interstitial edema as well. So this is another patient, a child who presented with this large lesion, which is a lobulated lesion within the lateral ventricle. And this is a case of choroid plexus papilloma. As you may know, choroid plexus papillomas are CSF secreting tumors. So these tumors will result in ventriculomegaly or hydrocephalus. So this is another case in which we can see that there is a large heterogeneous appearing lesion within the trigone of the lateral ventricles, and it's showing avid post-contrast enhancement. So this is another case of choroid plexus papilloma. So this is a patient who presented with urinary incontinence, gait disturbances, and dementia. This is a case of normal pressure hydrocephalus, and I want to mention few things that we need to consider when labeling normal pressure hydrocephalus. So in the figure A, you can see that there is bowing of the corpus callosum, and the figure B, they've measured the Evans index. So Evans index has to be more than, has to be increased. Then figure C is depicting the callosal angle. So callosal angle is narrowed in cases of normal pressure hydrocephalus. Normally it has to be between 100 to 120 degrees. So you can clearly see it's narrowed in this case. Then you can see the widening of the sylvian fissures. And then in figure E, you can see the enlarged subarachnoid spaces. These are the enlarged subarachnoid spaces. And then tight interhemispheric fissure. And in figure F, you can see that there is focal bulging of the roof of the lateral ventricles. So these are the characteristic imaging findings that you would see in a patient of normal pressure hydrocephalus. So this is another patient with normal pressure hydrocephalus. Just wanted to add few slides of CT as well. And again, you can see the similar parameters. So this is the callosal angle, Evans index. In this, you can see that there is rounding of the frontal horns of the lateral ventricles due to ventriculomegaly, then dilated sylvian fissures, and tightening of the subarachnoid spaces in the along the vertex, and dilatation of the temporal horns of the lateral ventricles. So the things that we had described earlier in cases of NPH are basically graded, and if the Evans index is more than 0.3, it's graded as 2. If there is narrowing at the level of paraphel sign region, then it's graded as 1, and if it's along the vertex, then it's graded as 2. Then you have to look at the sylvian fissure. If there's enlarged, then you grade it as 1. Then if they're focally enlarged sulci, which we had seen in our case, so you grade it as 1. And if there's dilatation of the temporal horns, you have to measure the diameter. If it's more than 6, then it's grade 2. Then callosal angle, if it's less than 60, then it's grade 2. If it's 90 to 60, then it's grade 1. And then periventricular hypodensities, if they are in the frontal horn, then it's grade 1, and if they're confluent areas, then grade 2. So the higher the grade, that depicts the severity of NPH. Moving on to non-communicating hydrocephalus, it's associated with raised intracranial pressure and is commonly caused by midline tumors due to the location. Additionally, compression of the subependymal veins result in periventricular interstitial edema. I'm going to talk about acute versus chronic hydrocephalus. So acute hydrocephalus, in acute hydrocephalus, the most significant finding is the periventricular hyperintensities on T2 or FLAIR images, which is depicting the acute interstitial edema. Then there is ballooning of the frontal horns of the lateral and third ventricle. Then fourth ventricle is usually normal in size. Now, acute hydrocephalus is an emergency and it should be treated urgently. And unless the condition is treated urgently, it may lead to serious complications, including persistent blindness, cerebral infarct, herniation, or death. In contrast, if you talk about the chronic hydrocephalus, the temporal horns may be less prominent than in acute hydrocephalus. Corpus callosum may be atrophied. With long-standing untreated hydrocephalus, white matter will undergo irreversible demyelination. So these are the CT axial images of a patient who presented with subarachnoid hemorrhage. You can see the hyperdensity within the cortical sulci. And then this was followed by placement of the ventricular drain, and a week later you can see that there is interval resolution of the subarachnoid hemorrhage. A few months later, in the figure C, the patient presented with complaints of headache, and in this image, you can see that again there is development of dilatation of the ventricles with associated periventricular hypodensity, suggesting acute hydrocephalus. So these are basically two patients. If the figure A is depicting the chronic compensated hydrocephalus and B is showing the acute decompensated. So in chronic, you can see that there is lack of periventricular CSF resorption. And in B, you can see periventricular hyperintensity consistent with interstitial edema due to acute decompensated hydrocephalus. So infectious etiology are one of the most common causes of hydrocephalus, with bacterial or tubercular meningitis being associated with it. Tuberculous meningitis is pathologically characterized by occurrence of thick basilar exudates. So in this case, you can see that there is on the top are the CT images. You can see that there is dilatation of the ventricular system with periventricular hypodensity. And on the bottom are the post-contrast axial sections in which you can see that there is thick nodular enhancement at the level of basal systems and surrounding areas consistent with TB meningitis. Intraventricular hemorrhage is a common cause of hydrocephalus in premature infants, and there is significant enlargement in more than 50% of the patients with IVH. The intraventricular blood leads to subependymal gliosis, fibrosis, and adhesive arachnoiditis results in ventricular distension. So this is an image of a neonate in which we can see that there is bilateral hemorrhage in the caudothalamic groove. It's more marked on the left side, and then you can see that there is prominence or the dilatation of the ventricular system. Again, on the subsequent image, you can see that the ventricles appear to be dilated. And this is a case of grade 3 IVH with hydrocephalus. In grade 1 and grade 2 IVH, we do not see the dilatation of the ventricular system. However, in grade 3 and grade 4, there is hydrocephalus. In grade 4, there is additional intraparenchymal hemorrhage as well. So these are the axial CT images in which we can see the subependymal nodules. This is a case of tuberous sclerosis. This is a non-calcified nodule, and this is a calcified one. And you can see various scattered ependymal calcified nodules in the periventricular region and in the foramen of Monro, resulting in hydrocephalus. These are axial sagittal T1 and axial T2 weighted images which demonstrate a lobulated heterogeneous solid cystic mass which is attached to the septum pellucidum, and it's causing obstruction at the level of foramen of Monro and resulting in non-communicating hydrocephalus. This was a young patient, a 30-year-old male, who presented with, this is the case of central neurocytoma. So these are axial non-contrast CT head, which is showing shows dilatation of the lateral ventricles, and then a heterogeneous mass, which we can see here in the suprasellar region. Coronal T2 weighted MR image shows that there is a heterogeneous mass within the pineal region with resultant dilatation of the lateral ventricles. And in the post-contrast image, you can see that there is heterogeneous enhancement of the suprasellar and pineal mass. And you can see the hydrocephalus. So this is a case of pineal and suprasellar germ cell tumor. So this is again a case of pineal gland tumor in which you can see that there is a T1 isointense lesion at the level of pineal gland, which is showing enhancement on post-contrast sequences. And in figure C, you can see that there is prominence of the ventricular system with prominent temporal horns. And again, on post-contrast sagittal sections, you can see an enhancing lesion at the level of pineal gland. So these are sagittal T2 weighted image, which demonstrates a well-defined tactile mass, which is ISO2 hyperintense on T1 weighted images, and of flare images, it's showing, it's appearing hyperintense. And then you can see the obstructive hydrocephalus, which is secondary to this mass. So this is a case of tactile glioma. So these are multiple sections from the MR of a young patient in which we can see that there is a large heterogeneously enhancing lesion at the level of the fourth ventricle, and the lesion is causing supratentorial hydrocephalus, and this was a case of ependymoma. Another case in which axial T2 weighted image shows a hyperintense mass within the right cerebellar hemisphere, and there is a nodule, hypointense nodule, which you can see here along the periphery. On post-contrast images, you can see that the nodule is showing avid post-contrast enhancement, and on subsequent coronal images, you can see that this is the lesion which we were seeing here. In addition, we can see another avidly enhancing lesion at the level of vermis, which is resulting in obstructive hydrocephalus. So basically, these lesions are causing a significant pressure effect over the fourth ventricle, which is causing supratentorial hydrocephalus. So this was a case of hemangioblastoma. So these are the DWI sequences. You can see that there is a large area of hyperintense signals involving the right cerebellar hemisphere. So this is consistent with an acute posterior inferior cerebellar artery infarct. This is causing pressure effect over the fourth ventricle, resulting in prominence of the ventricles and with periinterstitial edema consistent with acute obstructing hydrocephalus. Another case of cerebellar infarct in which you can see that there is diffuse hypodense signals seen within bilateral cerebellar hemispheres, and there is hyperdense signals, hyperdense areas noted within the sinuses, which is suggesting pseudo-arachnoid sign. And these bilateral infarcts are causing significant pressure effect over the fourth ventricle, resulting in supratentorial hydrocephalus. So this is a case of bilateral cerebellar infarcts. So this is another case which shows a cyst within the fourth ventricle, and the non-contrast CT shows the dilatation of the temporal horns. In addition, you can see few calcifications within the brain parenchyma, which are suggesting the nodular calcified stage of cysticercosis. So I would want to mention that there are few conditions which mimic NPH, and one of them we encounter quite commonly is normal aging brain. So we need to be able to differentiate between the normal aging brain and NPH. So in this, you can see in the figure A that there are enlarged perivascular spaces, which you can see here. Then you can see that there is prominence of the ventricular system, which we can see in cases of NPH as well. Then in figure B, you can see that the callosal angle is within normal limits, which is narrowed in cases of NPH. These are the SWI sequences in which we can see that there is signal dropout in bilateral globus pallidi, which is physiological and depicts that this is the aging, normal aging phenomena. And in figure D and E, you can see that there are subcortical flare hyperintense signals, which are suggesting that these are chronic white matter ischemic changes. So these are the changes which you would see in cases of normal aging brain. And this is how you differentiate between normal aging brain and NPH. Another condition which I wanted to add is of Alzheimer's disease. And in Alzheimer's, you would see the prominence of the ventricular system and sulci. As you can see here, it's quite similar to NPH on the axial sections. Whereas on these axial temporal area, you can see that there is significant atrophy of the temporal lobes bilaterally, with significant prominence of the temporal horns of the lateral ventricles. In contrast, if you look at the occipital lobes, they are not showing any atrophy. So this is how you differentiate NPH or normal aging brain with Alzheimer's disease. In addition, you can see that there is bilateral symmetrical mesial temporal lobes showing atrophy, which is seen in cases of Alzheimer's disease. So in conclusion, hydrocephalus is a complex disease, and deep knowledge is necessary to better understand each individual problem we are facing in our routine clinical work. Imaging is required to differentiate non-communicating from communicating hydrocephalus. Early detection of acute non-communicating hydrocephalus, which requires emergency surgical decompression, can be life-saving. Further research to improve our understanding of causal mechanisms and pathophysiology is necessary to optimize treatment and outcomes.